Hi, everybody. We are going to be discussing the second part of the urinary system lecture. So last time we described the anatomy of the nephrons as well as the kidney. We talked about the nephron and the microscopic anatomy of the nephron, which is basically the functional unit of your kidney responsible for the production of urine. Now our our lecture is going to shift to how your nephrons produce urine. Urine is produced through three separate steps known as glomerular filtration, reabsorption, and secretion. We're going to take a look at each of these steps. We're going to look at the locations of each of these steps through the nephron and what actually moves during each step. So let's go ahead and get started with the glomerular filtration. So filtration happens in the glomerulus, which is basically a network of capillaries within the renal corpuscle. And anything that is filtered during this process enters the first part of the nephron tubules, which is your proximal tubules or PT. Now, one of the reasons that you can filter some components and not others is based on size. So let's take a look at a depiction of what is happening when we are talking about the process of filtration. So here is basically my glomerular capsule. We are going to bring in the blood vessel afferent arteriole coming in. So this is my afferent arteriole, which becomes my glomerulus, and then it comes out as efferent arteriole. Now, this is basically, since these are blood vessels, you have components of blood inside here. So within your blood, you have your red blood cells, you have your white blood cells, and you have the fluid part of the blood, which is plasma. Now, what is inside the plasma? You have proteins, you have water, which basically again makes your blood fluid. You have ions, you have glucose and things like amino acids, and you have urea and uric acid, which are your waste products basically. The easiest way I want you to think about this is, do we see these in urine or not? If you see them as urine, they must have been filtered. If you typically don't see them, then they probably weren't able to be filtered in the first place. Of course, there's exception to that rule, and I'll tell you what these are, but that's the easiest way of approaching this concept. So, do I normally want to have red blood cells in my urine? And the answer is no, because that means I see blood in my urine. The reason, again, I won't see that is because red blood cells are too large. So they cannot pass through the tiny holes that I have inside the glomerulus. White blood cells are even larger than the red blood cells, so I would definitely don't want to see them. Again, there is exceptions to the rule. Plasma portion. Do I have water as part of the urine? The answer is yes, which means it has to be able to be filtered, which means they're small. Ions. Ions are your salts, sodium, potassium, calcium. Do you see them in urine? The answer is yes, because it is something that I can balance and get rid of the extra ones if I have any, which means they should be able to also filter. Urea and uric acid. These are our waste product, which means at some point I need to get rid of them, which means, again, they would be small enough to pass through the holes of the glomerulus and get into my proximal tubules. Now, what remains is glucose and amino acid. I want you to think about this as the fact that if somebody is diabetic, they test positive for glucose in urine, which implies that glucose must be small enough to pass through the little holes of the glomerulus. Now, can proteins pass through? Again, under normal condition, proteins will be too large. They're made up of hundreds, sometimes thousands of amino acids put together, which means that you may be able to pass individual amino acid, but not when they are stacked hundreds upon hundreds of them together. The structure would be too large. So when molecules pass through what is passing through and it gets entered into the proximal tubule through the process of filtration, which is basically our arrow, the fluid that enters the proximal tubules is referred to as filtrate, which is, again, kind of logical. So what is part of my filtrate? I will have water, I will have my ions, I would have urea and uric acid, I will have glucose, and I will have amino acids. Everything else and the rest of the proteins, water, and ions that weren't able to filter through go through the efferent arteriole and continue to become the peritubular capillaries. So let's go ahead and take a look at the next step of the process, which is reabsorption. So where does reabsorption take place? Reabsorption, first of all, is described as the movement of molecules from the filtrate, which is the fluid that's in the renal tubules, inside the renal tubules, back to the blood. We call it reabsorption because re means reclaiming, right? Repeating of absorption. So absorption, let me break down the word for you so you can understand it. Absorption is when you bring things in the first time, right? So your digestive system, you ate something and that those molecules, wanted molecules, move from the digestive system or absorbed into your bloodstream. During the urinary system, you take those molecules and you push them back into the PCT or PT. But you change your mind, say, no, I want you back. So I'm going to reclaim those molecules back into my system. So that's reabsorption. Now, where does reabsorption take place? Again, it happens throughout the renal tubules, but each part of the renal tubules has its own specificity in terms of what they're absorbing. So we're going to talk about the first part of the tubule, which is proximal tubules, what is happening in the descending limb, what is happening in the ascending limb, and what is happening in the distal tubules. So let's go ahead and get started. The way I have depicted here, you have the glomerular capsule. Glomerular capsule is connected to the proximal tubule, which contains your filtrate. And when the molecules move from the proximal tubule into the peritubular capillaries, that's the process of reabsorption, which you see as these blue arrows. So what is happening in the proximal tubules? 100% reabsorption of glucose and amino acid happens. Do understand that both amino acids and glucose are extremely essential for your survival. You took a lot of effort to bring those glucose and amino acids into your system. So you should not normally allow these molecules to be removed through urination. So proximal tubule is the most effective structure and it absorbs 100% of glucose and amino acids. Again, there is exception to this rule, especially in terms of glucose, where a person is diabetic. On top of that, you also have 65% of reabsorption of water and salt, which is your NaCl inside the proximal tubules. Basically, your proximal tubules is extremely important for absorption, what is important for us. Now, this picture depicts the descending limb and the ascending limb. If you guys are confused about this, you're welcome to label this for yourself. So look at the arrows are moving down, making this the descending limb, and arrows moving upward in terms of fluid movement, making this side your ascending limb. And this whole thing would be your nephron loop. So descending limb, the only thing that you're gonna reabsorb is water moving in. So as you go down the descending limb, more and more water gets reabsorbed. And as you go up through the ascending limb, you reabsorb lots of salt. So descending limb, your sample becomes super, super concentrated by the time it gets at the bottom of the loop. And then as soon as you start to go up through the ascending limb, you start to reabsorb more of the salt, then your solution is back to normal concentration. So up to this point, we have talked about proximal tubules in terms of reabsorption of glucose, amino acid, water, and salt. We talked about the descending limb being extremely important for absorption of water and water only. The ascending limb was important in terms of reabsorption of salts or ions, and that only, so nothing else gets reabsorbed at that point. So the only thing we haven't talked about is the distal tubules. Distal tubules is the structure that is going to be very particular about the need of the body, and it decides what your body should or should not take. So it literally looks at how much water our body requires, how much salt does your body require, and depending on the need of the body, it will get rid of the extra ones. And if it does need something, then it reclaims it back or reabsorb it back into the system. Now, distal tubule does not work on their own. They require the input of hormones, and the two main hormones that controls that process are aldosterone and antidiuretic hormone, or ADH. So briefly looking at these hormones, we're not going to get into details about them, but we'll look at them in just a minute. But before we go ahead and talk about these, we want to talk about the last step of the urine production process, which is secretion. Now, secretion is a process where molecules move from the blood vessels or peritubular capillaries into the nephron tubules. So in another sense, this is a process which is reverse of reabsorption. So here's how I want you to depict it. Let's say here is my PT, and here is my peritubular capillaries, okay? And again, this is true for the whole nephron tubule. It's not limited to only PT. It's present in the descending limb, present in the ascending limb, and it's also present in the distal tubules. What I want you guys to look at is, if the arrows are going from the tubes into the blood vessels, from the tube into the blood vessels, the red arrow depicts reabsorption. If the arrows are reverse direction, they move from the peritubular capillaries into the PT, this is considered secretion. So when we look at the movement Again, the arrows are moving in the opposite direction, and that is one is reabsorption, the other one is secretion. Why do I need secretion? Secretion allows us to remove harmful material like drugs, extra hydrogen, etc., through a means of active transport, which basically means that we use energy to get rid of things that are harming our body or are unwanted to us. And lastly, when we're done basically with this whole process of reabsorption, secretion, whatever that is produced at the end is called the urine, and it empties into the collecting duct, eventually goes all the way to the renal pelvis, and by the end of the process reaches the urethra and out of our body. So let's talk about the process here. This is a really good picture. I really like it, so I'm just gonna go over it with you guys. So this is putting everything we learned in one place. So renal artery brings the blood through many branches. It becomes afferent arteriole, which becomes the glomerulus. Glomerulus is where you have your filtration. Here's the color coding for the arrows. It allows salt, uric acid, amino acid, glucose, urea, and water to filter through. So when it enters the proximal convoluted tubules, or just PT, some molecules can move from the renal tubules into the blood vessels. Look at the direction of the arrow, going into the blood vessels, and that's the reabsorption process. At the same time, you can see the arrows throughout. At the same time, some molecules can move from the blood vessels into the renal tubules, which is reverse of the reabsorption, and the blue arrows depicting the secretion, allowing us to get rid of the unwanted material. Now, one of the last things I want to talk about with you guys is the two main hormones that are associated with your water and salt balance, which is aldosterone, I mentioned earlier, targeting your distal convoluted tubules. And the second one is antidiuretic hormone, which is essential in terms of controlling your blood osmolarity, or basically the concentration of your blood. So let's just start by talking about aldosterone. Aldosterone is part of a system called RAS. You don't need to know what that stands for. However, it is a system that helps you balance or control the levels of sodium and water in your distal convoluted tubules, or again, simply DT. So when does this system get activated? This system gets activated when your blood pressure is low. So when your blood pressure is low, typically that means you don't have enough water, and that's not something that is really good, right? Because if your blood pressure is too low, your system or your circulatory system will shut down. So what happens? You have these tiny glands on the surface of the kidney, or superior on the kidney, called the adrenal glands. And they are literally, if I was to depict them, here is your kidney, the bean-shaped kidney, and there is this pyramid gland sitting right on top of your kidney, and these are called the adrenal glands. So you have two of them technically, one on the right and one on the left. So these glands, these adrenal glands, release a hormone called aldosterone. Aldosterone is going to cause your body to, or more specifically your renal tubule, to reabsorb the salt, and at the same time get rid of the potassium. So basically you're bringing a positive ion in and you're getting rid of a positive ion. It's kind of give and take. Now, understand anywhere that your salt goes, water also follows. Kind of remember, I always told you guys, if you eat something salty, you want to drink water right after. So same thing happens in your kidney. As you start to reabsorb your salt ions or Na, you then also follow, water also going to follow, which means the water reabsorption is also increased. Now, as you increase your water, the blood volume increases, and that causes the pressure to also increase. So this whole system started because your pressure was low, and the way you improve the pressure is by literally bringing more water into the system, which causes the blood volume to go up, which in turn causes the pressure to go up. Another system that we have is a hormone called antidiuretic hormone, or ADH. Anti means opposite, diuretic as in water loss. So ADH is produced by a gland we talked about before in the nervous system called the pituitary gland. It's specifically, should I say, produced, it's released by a gland on the posterior aspect of the pituitary gland called literally ADH, or the hormone called ADH, and it's released when your blood osmolarity is high. Basically means you have not consumed too much water and you have way too much salt in your body. So in these scenarios, your basically body says, I don't want to get rid of water anymore. So hence the name antidiuretic, as in I do not want to remove extra water from my system. So how does this work? Your posterior pituitary gland is going to release the hormone ADH. ADH is going to go and target again your distal convoluted tubules and the superior part of the collecting ducts. And it's going to insert what we identify as aquaporins. The aquaporins are basically proteins that allows the water to be reabsorbed at a fast rate. So ADH targets your the end tubules of your nephron, and by inserting aquaporin, it increases water reabsorption. The more water you reabsorb, the more dilute your blood becomes, so the osmolarity or the concentration of your blood decreases. Please do understand that when ADH is in play, you are reabsorbing higher amount of water, and therefore your urine becomes more concentrated because you're not losing that water out of your system. So logically, if you are dehydrated, your volume is more concentrated. Now, in the same note, couple of things to understand. Alcohol is identified as a diuretic. It is because it is diuretic because it limits the release of ADH. Again, ADH is your antidiuretic hormone. So when you are required to have ADH in your system, then your drinking alcohol causes reabsorption of the water to decrease because it literally inhibits or suppresses your ADH. So when there is not that much ADH, your water is going to be removed out of your system, making your urine highly dilute and the volume of your urine pretty high. So if I ask you, is it a good idea to drink alcohol when you're dehydrated? And the answer is no. Because when you're dehydrated, take a moment to think about it. When you're dehydrated, you want to have high levels of the hormone ADH, because that hormone is going to pull water and bring it back into your system. And it doesn't allow it to be lost through urine. Alcohol says, no, get rid of that extra water, suppress the ADH. So they literally work against each other. And alcohol is the one that is going to basically prevent your body from absorbing the water it needs, and therefore makes you even more dehydrated. Caffeine is another thing we have. Caffeine is another diuretic. that is causing the afferent arterial diameter to increase. Recall that the afferent arterial is the blood vessel that brings blood to the glomerulus. So if you're pushing more blood to the glomerulus, then more filtration is going to be produced, or your filtration rate increases, which means more filtrate will be produced. And the more filtrate, the more urine you're going to produce. It also decreases the ability to reabsorb salt. And if the salt is staying inside your nephron tubules, then water is also staying in the nephron tubules, which means that water is going to be lost from your system, and therefore caffeine will be identified as a diuretic. So understand the two types of diuretic. Alcohol affects the hormone ADH, versus caffeine affects the size or the diameter of the afferent arterial and the ability to reclaim water through loss of sodium. You may also have heard of the word hemodialysis or simply dialysis. This is really common in individuals who are undergoing kidney failure as a result of either chronic or acute renal failure. As an over time they're losing function of the kidney, or suddenly losing function of the kidney. In either case, your hemodialysis is a machine that's going to act like an artificial kidney, limiting the ability of the body to, increasing the ability of your body to deal with the unwanted material in the blood by taking the blood, cleaning it up, and then returning that filtered blood back into your system. In some cases, machines also add helpful molecules such as bicarbonate, which is your buffer, to help maintain your pH. Now I'm going to backtrack to a concept for the urinary system and diabetes. I think this is one of the most fascinating concepts we have for our body. So let's take a moment and think about this. So we learned earlier that 100% of the glucose can be reabsorbed in your PCT or PT. So here's my PT. Here is my glucose molecule. And let's say on the top, you have your peritubular capillaries. So something that you want to understand is that even though we said 100% of the glucose is going to be reabsorbed, there is still a limit to that. So this is under normal condition. So let's say, and this is arbitrary, they're not actual workers, they're proteins. Let's say there are 100 proteins here, or workers, that allow the glucose to go into your system, basically picking up 100% of the glucose. Now, these proteins have a capacity. So under normal condition, if you eat a certain amount of glucose and it doesn't reach the maximum capacity of these proteins, then 100% of the glucose gets reabsorbed. So arbitrary numbers. Let's say you have 100 glucose molecule, right? And the capacity for these proteins is, let's say, 200 glucose molecules, okay? Again, these are numbers to just kind of give you a clue. So these protein can move 200, but you only have 100 glucose. So they say, oh, I can handle this. This is fine. But when a person who is diabetic, what happens is the glucose level is increasing much higher. So instead of only 100 glucose, let's say you pack 500 glucose molecules into the system. So the first 200 gets absorbed into the system. The other 300, your body says, I am not capable of working faster to reclaim those glucose molecules. So the other 300 molecules of glucose pass through the PCT or PT without being reabsorbed back into your system. Remember that the rest of your renal tubules are not meant to reabsorb glucose. The only part that can reabsorb glucose is your PT, and you already lost your chance of reabsorbing those glucose molecules, which means the glucose is going to go through the descending tube, through the ascending tube, distal tubule, and become part of the urine as it enters the collecting duct. And that eventually going to be excreted from our body. So, body is unable to reabsorb all the glucose molecule as it passed through your PT or PCT. The excess glucose in the nephron tubules keep the water in the tubules and prevent reabsorption. So what does that mean? So remember salt and water. Water always follows salt. Same concept applies in terms of glucose or sugar. If you have 300 glucose molecules that are remaining here, then water also says, oh, I'm gonna stay with glucose. It doesn't mean that all the water is gonna stay. Some water is still gonna follow the glucose and go back into the peritubular capillaries. But at the same time, some of that water stays with the glucose because glucose and water go together. So in that scenario, as the glucose is getting excreted out of the body, you're also going to lose excess amount of water because water is staying with glucose. In such scenarios, urine volume does increase even though your body may need that water. And that person is continuously thirsty because they're trying to replace the water they have lost because of the presence of glucose in the urinary system. So that's about it in terms of urinary system. So we'll finish our last lecture about reproductive system for our next lecture.